Hello and welcome to WBAE. So we will deal with a case today, and this patient was a 28-year-old male patient, but he was referred to us from the pulmonary department. This patient had a history of pneumonia in four months back, and the patient was having a progressive shortness of breath. They have done all possible investigations from the pulmonary side, and they are convinced that it was not a pulmonary case. And when the patient came to our OPD, this was my patient's neck vein. It was a pounding neck vein with engorged neck veins, and they have given us an X-ray, and this X-ray will clearly show us that this patient doesn't seem to have a very exaggerated pulmonary hypertension. Neither the patient has a cardiomegaly, which will show that this patient has pericardial effusion. So we have something else with this patient which has caused this neck veins, and we went straight away for the echo. And this was the first echo. We can see that the LA was dilated, the LV was not that dilated, it was rather chinked, and there was an unusual bouncy movement in the IVS which we saw. And this type of movement we also find in case of bundle branch blocks patterns. So we wanted to clarify whether we are dealing with something else or not. There was not much mitral regurgitation or not much aortic regurgitation or aortic stenosis in this patient. And if we see this view and we can see this M mode, we will see that the LA is just a bit dilated and nothing significant. When we were doing the ejection fraction by the TCOS method, we saw that the ejection fraction was 65 millimeter of mercury, but the typical bounce was seen here in the IVS in the diastolic phase. And in the early part of the diastole, if we compare this with the ECG, we can see, and of course, your eye impression will also tell you. So, this was the Plaque's view, and you can see that the diastolic bounce, the bouncing movement in the IVS, which was very classical. And if we have taken this movement along with the mitral valvular opening to show you that the bounce was classically in the early part of the diastole. So it was a diastolic bounce that this patient was having, and the RVOT was dilated, but side by side you can see that the pulmonary artery, they are not at all dilated. And here also, if you see in this is a right ventricular type of a view, in which there is a flattening of the IVS, so that showing that there is right ventricular overload pattern, and the typical bounce, diastolic bounce of the IVS is also very classical. This is the pulmonary artery to show you that there was no significant pulmonary regurgitation, and both the pulmonary branching are also very okay. And this is a very classical finding in the fourth chamber view, in which you can see that during the diastole there is a fluttering movement in the IVS, which is very classical. And see, what is happening is during diastole, when the LV is trying to expand, after a stretch it cannot expand, and that it cannot expand, it starts fluttering like that, which is very classical finding in case of a constrictive pericarditis. So we have done a LA volume and RA volume, both are significantly raised, and this we have done an LA volume index which shows 58, which is significantly on the higher side, more than 45. We look at the pulmonary color flow, it's more or less it's the mitral color flow, it's almost normal. The mitral PW shows an E more than A, which is almost normal looking. And if you see this view, in which the mitral excursion of the medial annulus is slightly more than the excursion of the lateral annulus. See, and I have taken both in the same frame. The left side is the lateral and the right side is the medial. and the lateral annulus excursion is less, which is annulus reversus, which is very classical of this constrictive pericarditis. Once we are heading towards the diagnosis of constrictive pericarditis, I tried and looked at the pericardium by pericardial thickness from the subcostal view, and see the distance was 5.4 millimeter, which is clearly in excess of 2 millimeter, which is the upper limit of the pericardial thickness. The TR gradient was not much raised, it was just 14 millimeter of mercury. And see, when we saw the IVC was collapsing but less than 50% normal, but the collapsibility was there. So we did a LV strain pattern, and we saw that the LV strain pattern was almost normal and almost similar. And when we did a bullseye, the bullseye also showed that there is no significant strain pattern, only there is a little bit of a higher strain in the anteroseptal and the inferolateral part. This was that we had got from the pulmonary department. They had given us a film of a chest CT, and I have kept this film just to show you that the thickening of the pericardium was very evident in this film as well. This is of course another view. This is not of the same patient. This is another of our patients. I wanted to keep this photograph because to show you a clear case of concretio cordis, that is a severe calcification of the pericardium. Interesting case with this patient was, then when this patient came to us, it was very difficult for us to find a definite window through which we can see the apical four-chamber view. We tried it out from the apex, we tried it out from the subxiphoid area, but what we saw was we could not really find out a good window so that we could prove that this was a case of pericardial disease. We had taken the patient then for a cardiac MRI. What happened is, since this patient was having a heart rate of more than 120, this cardiac MRI people, they also didn't want to do a positive reporting on this patient. Our junior colleague, he took the patient for a chest X-ray, and the chest X-ray, when it came out, it was so classical, we could find out that this was the calcified part of the pericardium which was hindering our views. So this was an interesting case, very much in corroboration with a constrictive pericarditis. I show you this. This is again the second patient. This was a lady around 58 years old. She was treated for multiple myeloma. She was a hypertensive for quite a long time, and she was on antihypertensive treatment. So when we saw the echo of this patient, the patient did really have a concentric LVH, did really have a dilated LA, but something struck us, which we saw that even the mitral leaflet and the aortic leaflet, they also looked to us a bit thick. So we went on for the further examination. See, there is a chink of pericardial effusion, not amounting to cardiac tamponade. There you have a definite aortic regurgitations, the aortic jet plunging on the anterior mitral leaflet. And this was the contraction. There is no regional wall motion abnormality. The concentric hypertrophy is definitely evident, and there is a chink of pericardial effusion as well. This was the four-chamber view. You can show the dilated LA and the dilated RA, and we have done the RV strain. The RV strain was minus 9.2 to minus 12, which was definitely less. Then we did an this was the typical small MR and the small TR. The AR was significant, which I told you. And in this decoy method, when we wanted to do the LV ejection fraction, what we found was the LV and the IVS and the posterior wall was significantly dilated, and the EF was 54, which was not that bad. But the TAPSE showed that it's a blunting TAPSE, in which the TAPSE was only 17. and this was the IVC. The IVC was dilated, and we measured the IVC to be more than 20. It's 23. The mitral pulse wave Doppler, they showed that the E and the A ratio is more than 2, and there is a significant restrictive feature in the mitral pulse wave Doppler. We did the annular excursion, and the medial annulus and the lateral annulus both showed that the excursion was really blunted. And if you want to find out, you can find out, this is the 5 and the 5 mark. All the values were between 5, the E prime, the A prime and the S prime, all were between 0 to 5. And this was the classical 555. Here also it was less than 10. This is the 5 mark. It was around 5 in the lateral annulus also. This is a classical 555 type of restrictive cardiomyopathy disease. The aortic valve and the pulmonary valve and this tricuspid valve showed definitely gradient of 37, which showed that the patient had pulmonary hypertension. The RA was dilated significantly. The LA volume was 64, which was also significant. And see, the LA strain pattern also showed less than 7 was the average strain. We did a LV strain pattern, and the classical cherry on top appearance of the LV strain bullseye view was found, which showed that this patient, we were dealing with a patient of restrictive cardiomyopathy. So we tried to show 2 cases side by side to you, one being a case of constrictive pericarditis and one base being restrictive cardiomyopathy. In the restrictive cardiomyopathy, you see a concentric LVH type of a picture right in the vertigo with a dilated LA and RA. And in constrictive pericarditis, you always have a dilated LA and RA, but the movement of the LV is much better, and there is a classical diastolic bounce in the LV. If we do a strain pattern, you can see that there is a classical strain pattern of restrictive cardiomyopathy, but the strain pattern of constrictive pericarditis is always normal. And if you want to further assess your patient, you can try and measure the pericardial thickness in case of constrictive pericarditis. That will give you a better picture. I'm happy to ask you, take your questions. Thank you.